the agenda? Okay, Alana, we're looking for you to share screen. Are you able to do that? Okay. All right, so we just want to give everyone a glance. Good afternoon. And before we get started, we are showing the agenda. You are participating in the Maryland Primary Care Program Advisory Council virtual meeting. We sent out a draft agenda with the email invite. It was marked draft. We've modified it just slightly. Let me just walk you through it real quick. Some basic introductions. We won't be reading off all the committee members or all the advisory council members this afternoon. There are those you can see. And then, of course, if you look to your bar on the right side of your screen, hopefully you're able to produce the list, and you can then see all the list of participants. As I mentioned, if you're dialing in only, we won't be able to see who you are. But at the same time, we remind everyone to keep muted if you're not planning or are in the mode of talking. We're going to have a couple opening remarks from Drs. Haft and Riedman. We will talk a little bit about the Track 3 Recommendations Committee that was convened and has now since been sunset. They were convened for a specific task. And then we're going to proceed into the Track 3 discussion areas. If you could scroll down a little bit, Alana, you'll see the areas that we plan to focus on largely fall into these three categories, but we'll walk you through the requirements grid that was developed. We'll talk a little bit about next meeting, some closing remarks by Dr. Riedman, and then we will get everyone out of here at 6:30 as promised. We appreciate your time and are looking forward to a meaningful conversation. Lana, if you can scroll back up to the top, I will turn the discussion over to Drs. Haft and Riedman.
David, do you mind if I say a few logistic things before we start?
That would be appreciated. Thank you.
Okay. Sorry for interrupting. So I just want to do some kind of housekeeping items, logistical items. So this meeting is being recorded. Please contact Anena or me or send a chat message if you're having any technical issues. You can mute and unmute yourself using the small button at the bottom of your screen that looks like a microphone. Please remain on mute when not speaking to reduce the background noise. Staff may mute you if there's a lot of background noise, but you can always unmute yourself if you'd like to speak. So you can use the chat function to send notes. It does send notes to all attendees. This technology does not allow you to send a message to a specific attendee on this call. Please announce yourself when you're speaking. And the last item is, since there's a lot of people in the meeting, we'd like to sequence the speakers when it's possible. We know that's not always possible, and sometimes you feel free to speak in reaction to something someone says. If you would like for the facilitator to call on you, one way to get our attention is to take a white piece of paper and fold it and hold it up. But again, you're always welcome to speak when you have a comment that you'd like to make. So at this time, I'll turn it back to David.
Thank you, Melanie. And so obviously the white piece of paper won't work for those who are dialing in, but we trust you will appropriately insert yourself. So we're going to bring down the agenda and remind everybody that we sent out at least an earlier version that's close to this, and go back to full screen, Alana, and then we will invite Drs. Haft and Riedman to make some remarks.
So Howard, I'm going to let you start, and then I'll go from there.
Thank you very much, Michael. First, advisory council members, it's been a long time since we got together. I'm very pleased that we can join again in this deliberation, even in this virtual method. And I just want to emphasize the fact that this is important work that you're doing, and your deliberations and suggestions will have a major impact on the future of healthcare delivery in Maryland and quite possibly across the nation. It certainly affects the way we deliver healthcare to millions of Marylanders every day. We've come to a point now where MDPCP has successfully completed year one of an 8-year program, and we're well into since we spoke last, a very atypical second year. And during these unprecedented times during COVID, I think where we really come to appreciate the real value of MDPCP and having an organized and coordinated primary care workforce. MDP practices, with their coordination, direction, the support they've received from the department and from CMMI have rallied in so many ways to protect the most vulnerable citizens in a very coordinated manner. It's not possible in any other state, with any state that is lacking this kind of state organized, coordinated resource that's married to public health. So this was kismet in so many ways that we were able to be positioned to do this at this time. Following this meeting, you'll receive council members receive the first draft of the annual report that we do to CMS for your review and comment. The report will reveal substantially the delivery system advances that were made during the first year, which included things that I think you're aware of: behavioral health integration, expanded access to care, data-driven care management in many ways, integrating the social determinants of health, reducing avoidable hospital and ED utilization. And in addition, you'll see that there'll be a link in the report to what I think we're probably most proud of in this program. And it has nothing to do with me or my team particularly, but our practices and our care transformation organizations and the hundreds and hundreds of testimonials that we've archived for people thanking practices, providers, and care transformation organizations for the work that's been done under this program. I think that's really the true test of the value that we bring. What you'll see missing from the draft that you have is the quality and utilization data for the first year. We're still awaiting those results to be reported by CMMI. We anticipate they will be reported before the end of the month, and we'll do an amended version for your review at that time. But right now, our MDPCP, our colleagues in CMMI on the MDPCP program placed a sense of urgency on what we're doing now. This evening, you'll be asked to focus on some proposed changes to both the payment and performance adjustments for the MDPCP program that could take effect as early as 2022. Kind of the sense of urgency that's been applied to this is responsive, we understand, from directions that they've received from their leadership that says that they would like to move forward with nationally with providing a greater degree of risk to the demonstration projects. And CMMI has provided additional guidance to the PMO and to this group that suggested that the models that would need to be cleared currently to meet the requirements that they have would need to substantially look like an existing already cleared model. And the only existing already cleared model that's not being sunset would be the primary care first model. That's why we've used that as the basis for building the proposal. As you know, the primary care first model has not yet been sunrisen, hasn't seen the light of day. It's due to start in 2021 if there are no further delays. But we're still using, since it has gone through the clearance process. So we're using that as a model. And you've been provided in the preliminary information with a crosswalk to compare MDPCP currently, primary care first as it's sketched out to begin, and then some preliminary notions from the sub on variations that might be made to make it more applicable to the state. So there's much to do, and much to do over the next several weeks to meet the imposed deadlines. And our goal here should be, as it always has been, our goal should be to build a sustainable healthcare delivery and payment system that can serve the people of Maryland, and we anticipate also serve as a model for those elsewhere across the country. And I just really rely on you, and I look forward to a meaningful and thoughtful discussion on how we can best do that to serve the people of Maryland and beyond. So those are my only comments.
Great. Thanks, Howard. I just wanted to, I want to make this brief because we've got a lot to get through, but I did want to thank the committee for coming. I really wanted to explain also, it's been obviously a very interesting time in history Everybody on this committee has been on the front lines, and I certainly know I appreciate that everything y'all have done and we've done for the state of Maryland and our patients and everyone else during this crisis. And I know that y'all have been overwhelmed, especially early on. For those reasons, we certainly postponed this meeting a number of months. However, despite that, CMS is sticking to their deadline, as Howard mentioned. So we do have a tighter deadline than we did originally, in no small part because of COVID, but I think we can get through it. We did set up the subcommittee for exactly that reason. We had conversations about 6 weeks ago about how we're going to get through this. So we felt that the primary care first model was a good basis for us. The subcommittee met and had some really good conversations and kind of narrowed down that list. And we felt that would give us some talking points and clean up the agenda for the rest of the committee. But I want to make sure everyone's clear that those are just the thoughts of the subcommittee. We're really looking forward to y'all's feedback to try to finalize this. Along the way, also about, I guess, a couple of weeks ago, CMS then asked for not just our deadline at the end of September, but they also asked for some information about what we were doing now. So we kind of cleaned that agenda up. We got that to them about a week and a week and a half ago. Howard then had a meeting last, I think Friday, Howard, with CMS to get their feedback on whether we were too far out of the realm of what they were thinking. So we didn't get too far ahead of them. And so what I'd like to do tonight, and we'll get to that in a few minutes after David says a couple of remarks, but I'd like to get to go through those items that the subcommittee comments. I'll let Howard give you all some feedback on what CMS thoughts were on those topics, and then we'll open the floor up to the rest of the committee to do feedback. We'd like to get through the first. We kind of prioritized it. Also, there are about 20 items on our template, but we prioritized the first 3 to the ones we thought were most important that we'd like to get through for this, at least this next 2 meetings, get through those and hopefully get to the full agenda over a couple of meetings. So I'm gonna, in the interest of time, I'm gonna keep moving, and I'll let David say anything else he needs to under our 3rd bullet item, and then we'll move into the conversation.
Thanks, Dr. Reedman. I think you've hit on everything. Why don't I take the opportunity to frame up the requirements table? Alana, if you can bring it up, I'll take a moment just to acclimate the council to what they're going to be viewing and the approach that we'll be taking. As Drs. Reedman and Half mentioned, we did convene a small subcommittee to help us frame up what we call topics for the larger group, the council, to discuss. Those recordings are on the MHCC website. They're also available through, I believe, the MDPCP website as well. What you have in front of you is essentially it's a draft requirements document. It's not baked. It requires attention from this council to really dig into what's the thought of the committee and to shape it from this stage forward. We've designed it just to give you a sense of how it's organized. The left-hand column is a count. You'll notice the first one is a highlighted item. That number is highlighted, as Dr. Reedman mentioned. Those highlights in this document signify areas that we wish to hit first in terms of the sequencing approach. The next area is the design elements, which are the total monthly payments, which is the area, if you will, of top discussion. And then in the next category over, that is specifically what Primary Care First has as a requirement. And then the next column over, which Dr. Reedman will highlight for us once we get started, is what the council committee thought might be a good place to start. And then we'll invite Dr. Haft to give us some background on what CMMI said about what the committee proposed here. And then we're going to look forward to the committee weighing in on what's here, ask questions, make suggestions, propose something completely different. This is a policy discussion. We want to make progress tonight, but at the same time, we don't want to unnecessarily force everyone to just sort of sit on their hands when we're looking forward to great dialogue and great feedback from everyone. So, Dr. Reedman, I'll turn this back to you for getting us started.
Great, thanks. So what I want to do is, by the way, I meant to, I'd be remorse if I didn't mention or thank the subcommittee for the numerous hours that they spent reviewing the documents and the meetings we had. So I really appreciate their input. And again, look forward to the input from the rest of the committee. So the first item there, the total monthly payments, I'm gonna let y'all, you can look at the Primary Care First comments, and I think everyone hopefully has had a chance to read through this anyhow. The subcommittee's comments were that pretty much the same for that first item there. The practices are paid to deliver advanced primary care and in and outside the office. Practices focused on caring for patients with complex chronic needs and seriously ill receive the payments, increased payments to support their care. And there's two payments. We've been over this a number of times, but to remind everyone, there's a total primary care payment, and that payment will largely replace our fee for service for primary care physicians as we move forward. And there's two elements: a lump sum professional population-based payment, the PBP, and it's paid on a quarterly basis, a flat rate per visit for primary care physicians. And that number, I don't know if we have that on here. It's on there right now. That number is $40.82. That's the number that the Primary Care First programs come up with. But that's the number we're working off of right now, and that's a flat payment, as we talked about, for visits. And then there's in addition to that, there's the flat base rate per visit, which we just mentioned, pegged to Maryland's historical level primary to E&M visits for the year before the start of the T3 and updated annually. So, and then can you scroll a little bit north?
So that's it for that particular one.
So I thought there's another line there. So the first payment, I think I'd like to open it up to Howard to see what if there are any comments from CMS from his meeting, and then I'd like to open up the floor about the fixed rate and what they think is that number. And then we can go with talk about the rest of it after that.
So thank you, Michael. I think that the issues that we had raised and the response that we got from MMI were about, number one, about the way that the groups are configured under Primary Care First, as opposed to the way the groups are configured in MDPCP now. You know, now our tiers are based on individual patients and where they sit relative to other patients in terms of their HCC scores and the whole population that we serve. And then the compensation is based on each patient's risk level, that is, and then the payments are based on a per patient basis depending on the patient's risk. In Primary Care First, they take an average of the entire practice's HCC score, and then when it's within a certain corridor, then then you receive a certain level of population payment, and there are 4 different levels, and depending on where you sit in terms of not the individual patients, but your practice's HCC score relative to just overall HCC scores globally, will determine what your per beneficiary per month payment is for every beneficiary, independent of their individual risk. So it's based on the whole practice. It represents cliffs rather than gradations than in payment. So practices will either entirely be in one category, great group, or entirely in another. As these groups are configured, they're heavily weighted to the very high, the group 3 and group 4, people with very high HCC scores. There would be we haven't done a full analysis, but the preliminary kind of back of the envelope is that for MDPCP participants, very, very, very few would be in group 3 or group 4. Most would be in group 1, some in group 2, depending. So, but the majority in group 1 and group 2, so the lower per capita rate. And there are cliffs, so that if a patient gets worse or is sicker, or over time their HCC score changes, that wouldn't be reflected. It's based on the aggregate of the practice. So the big difference there is cliffs versus gradations in terms of payment. Practices would move entirely quarter to quarter, either up or down, depending on their average HCC score. And I think that was the major issue there that we had. And CMMI simply said they wanted a rationale for why we wanted to maintain the current way to aggregate or to configure per beneficiary per month's payments. I think that's probably the first point to discuss.
Alana, do you, just so the committee members know, do you have the sheet that has Howard's comments on what the group 1, 2, and 3, and 4 payments were for that? I think it's like the third or fourth page on that. Maybe. Do you have that? That in this? Yeah, I think it's maybe, there. You go.
And
I think you have to scroll up a little bit.
Yeah, you have to go up, Milana. There you go.
And there's a question from Debbie, so please proceed.
Thank you. Debbie Kuchka-Craig. I just wanted to clarify, we're talking about monthly payments, but the performance-based payment is quarterly. The flat fee would be paid monthly, quarterly, fee for service. I'm worried about, I guess I'm interested in knowing about the cash flow and whether or not that would be reasonably acceptable to the, especially the private practitioners out there.
Right. So my understanding is that the paid in advance is the population-based payment based on number of beneficiaries and what group you're in. And then a regular billing is a flat fee billing per visit that would go to Medicare and be billed so that there would be, depending on the number of visits, there would be a cash flow that would additionally come in on top of the quarterly payments.
That is correct. It's in the RFA, it's classified as a flat fee for primary care visit paid on a claim by claim basis.
Right.
Any additional comments, response to Dr. Half's feedback?
None.
Okay. Here.
There would be. It's worth pointing out we haven't done modeling for this to see whether the net effect would be neutral to what MDPCP is now, whether it would be a decrease or an increase, and if so, how many practices might see substantial increases or decreases based on this version of how you allocate per beneficiary per month.
And Dr. Half, does it make sense to talk about, we sort of have a group 5, if you will, a level 5 in the MDPCP, which is for complex, and how that might fit into this particular model where.
Yes, certainly. So this model also, it has lots of moving parts, first of all. Another moving part is what's called the seriously ill population. And that is individuals who are characterized, beneficiaries who are characterized in a different way than HCC score. They would have high HCC scores between 2 and 3, but they would also have avoidable hospital admissions during the course of the year. They would have decreased mobility and other characteristics that some are defined, some are yet to be defined, that would characterize them as seriously ill. They would be available to be allocated to either to seriously ill program participants that are standalones, which you haven't even contemplated that yet, or they could be aggregated for 1 year back to the practice that they have been attributed to already, and at that time they would, and it's for 1 year only, they would get an enhanced capitation payment, and they would be subject to a different set of quality measures and adjustments to that payment. So that would more or less correspond to our complex group, except that our complex group doesn't It just fits with the basic flow. This would be a separate kind of monthly or quarterly adjudication for individuals who would go in and out of that for 1 year and 1 year only, in and out of that SIP category.
Dr. Berenson. Thank you, Dr. Haft.
Okay, I want to ask, since our last meeting, I believe the CMS has noticed and comment rulemaking for the new fee schedule, which provides a substantial increase to primary care physicians by increasing the valuation of E&M visits. But it seems to me, I mean, has CMS in any way, there should be a pass-through of those increases. The estimate is that family physicians are going to get a 14% bump on their net allowed charges, and internal medicine about 10 or 11%. And I think the PMPM should be increased, and the visit level should be. Level 2 is going to be increased if that's the what it's set to. So the question is, has CMMI discussed raising these levels?
Dr. Haft?
No, not to my knowledge. In the current program, MD-PCP program, there is when the base rate or whatever the rates are, the applicable rates for payments go up. In the current model that we have, they do go up accordingly. I didn't see anything in the RFA for this that spoke to that. So I think that'd be an open question.
Yeah, that's a great question, Dr. Berenson. So we will take that back to the team at CMMI for just clarification.
Also along the same lines, the population-based payment that is here includes a very significant list of other services that are including our usual HCC, our usual CCM services, but it also includes a whole variety of other services that are not currently included in our excluded by our care management fees. So it's not truly apples to apples kind of comparison in that way.
Now, I understand they've added a complexity code for patients with longitudinal relationships with physicians, which I think would be applicable. Also, substantial increased funding for that. I have, as I've indicated before, I've got concerns that $40 and whatever change it is, 62 cents or whatever, is on the low side when you consider billing costs to get that. And at the very least, I think the level 2 fee should be upgraded to represented. I've wondered whether it should be some kind of, level 2 isn't billed very often. I'm wondering whether it should be some amalgam of level 3 and 4 and then discounted by some amount, which would also raise the fee modestly. But I know it's late in the game to change that. But if it is pegged to level 2, then I think they should pass through the level 2 increase at the very least, as well as increasing the PMPM to reflect the fact that there's 10 to 15% more money flowing to primary care.
Bob, that information came out this week. Last week you said?
August 4th was when they went to the Federal Register. There are summaries around it. I don't think it's yet been formally put into the Federal Register, but you can find it online, and there is a PDF of the rule. And every specialty society has summaries of what's in that proposed rule. Now, that's just a proposed rule. And I can understand why CMS might not want to commit to those fees until it's final, which now they're actually asking for only a 30-day period between the final rule and implementation, meaning December 1st. But at least at this point, they could at least give a commitment that they would pass through whatever the final rule increases are. Consistent with the model, which is to try to not put too much money into visits and having a single visit. But I think if there's going to be more money going to primary care, I do think that the visit level, the visit fee, the single visit fee could get a modest increase to make it more viable and have doctors more willing to bill it, as well as getting more into PMPM.
And Dr. Berenson, just a note, the $40.82 according to the RFA is the payment amount it reads roughly equivalent to the 2018 Medicare fee-for-service payment level 2 for these E&M services.
Yeah, that's right. I didn't know it was 2018. It doesn't match the current payment level even the 2020 payment level, which comes up short. And is that at the national level or the Maryland geographic adjustment level?
So they're saying there will be, on top of this fee, geographic adjustments.
Okay, well, I don't know why they'd use 2018 rather than something more contemporary. 2020 would be, I think, $6 more, and 2021 would probably be another $6 or $8 more. I'm just guessing.
Okay. Well, Dr. Reed, Melanie, please.
Bob Atlas would like to make a comment. He's on the phone.
Oh, absolutely. Bob, please.
Hi. Well, can you hear me? I made it onto video.
And now we can see you. Fantastic. Thank you for joining.
No. I tell you, I didn't know there were so many different platforms, and I get confused when I move between them. Can you hear me?
Yes, we can.
All right. Well, always enjoy and never want to argue with Bob Berenson when he goes into the details on these kinds of things. I guess I can't possibly get into the details on this, but maybe I missed it in the introduction. But can we talk a little bit about the big picture here? I mean, what is CMS's end game on this? It seems to be they're saying, we want track 1 to come to an end. We want everybody to be on track 2 or ideally track 3. I saw something in the back and forth markups of documents that said whoever, maybe Howard said we want to make this optional for practices, and CMS replied that was a non-starter. I mean, what's the big strategic issue here? Are we at loggerheads with CMS on this? Obviously, from the hospital's perspective, not only, of course, do we employ many of these primary care physicians and have CTOs, but this is in the eyes of CMS, this is adjacent to, if not bound with, the bigger total cost of care model. So that's my main concern, that CMS is somehow applying pressure that we need to understand.
Yeah, sure. Dr. Hack, do you want to just sort of bring us up to speed a little bit again? Maybe Bob probably joined a few minutes late on how we got here and the optionality of track 3 and what CMMI would like to do with track 1 and how the component of risk plays in.
Sure. So I think just a moment in history is the prior CMMI director, Adam Bowler, he had a very strong penchant for developing a system to take the place of CPC Plus, a model to take the place of CPC Plus, because the preliminary data from CPC Plus was not encouraging in terms of reducing the Part A costs, which was what his primary focus was. So he had conceived of this asymmetric risk program. He's subsequently left, but I think gave strong instructions to the staff at CMMI to create a next model that had asymmetric risk associated with it, focused on reducing avoidable hospital use. So that was a kind of a foment for this. The model substantially does that, and primary care first, and is one that that's going to be run out in a number of markets around the country to take the place and to be independent first, and then to take the place of CPC Plus for those who choose voluntarily to join it. So at the same time, during the change in administration leadership at CMMI, I think there was indication that that there should be also an alignment of the MDPCP program with what's happening with primary care first nationally. But not sure that that was to do a comparison or what the reason was, but it was clearly a sense of let's make this state program, let's change it so that it aligns with primary care first. Since that time, kind of the imperative has been to say, as I said, first to say we need to make a change, even though we're still very early in the program. We need to make a change, and then the change should align with something that's recognizable, and the only thing that's recognizable in clearance is primary care first. So that's how we got strategically and to get to this point. And I think now we're at a place where at the staff level at CMMI, they're very intent on making sure that they can have something that they can put through clearance that would be substantially recognizable as primary care first, and so that it would be able to, as early as 2022 and no later than 2023, be the next track for MDPCP, with asymmetric risk being the in a focus on avoidable hospital use as the focus, and leaving in the past by intention building infrastructure and those things. The assumption is that at this point that infrastructure has already been built by the systems, and this now takes that infrastructure and uses it to reduce avoidable hospital utilization. So I think that's the strategic direction.
So is there I'm trying to understand, is there a battle engaged or looming that's, they're insisting on track 3 being mandatory, and the Maryland squad is opposed, or are we trying to get to yes by figuring out these fee levels and the details?
So Bob, I think I think get to yes is kind of for sure. I mean, that's the end game of yes. And the question is, what is yes? I think we've all come to recognize that there is some weaknesses in the fee-for-service payment system that's really become apparent during COVID, but it's become apparent for a long time. And I think MDPCP in the current iteration was a step toward capitation. I think we're generally in agreement that practices would be better supported by larger amounts of non-visit-based payments and capitation, and that's what this takes us another step towards that. But the question is that in the details, that this was a program that was designed not for a state system as we have here, but it was designed to be a model to be run out around the country and see how it goes. We don't have any information on how it's going to go because it hasn't been done yet. So I guess the question is here, that we're now in negotiations with them, is saying, how do we change the current model to be closer to this? And they've never said it has to be this, just closer to this, and where the degrees of alignment need to be. So will it eventually be, is there a track 3 that's mandatory and we just move out of track 1 and track 2 into a track 3? I think that depends on what you call track 3 and whether it's generally applicable in the state. I mean, there's some things that in any model that might be impossible or at least off-putting for small or medium-sized practices to engage in for reasons of risk or other reasons, and that's not where we want to go. I think we should be very proud we've built a statewide system that includes small, medium-sized independent practices, anybody who can reasonably and well provide advanced primary care, and we don't want to start excluding people because of their risk-bearing tolerance. That's not the intention. I don't think that's CMMI's intention either. I think as we talked to them, they said we can make this mandatory, but make it mandatory in a couple of different versions. So that becomes semantic at that point. But I think where we are now is that we need to help them get to a place that makes sense for them and makes sense for us. It satisfies everyone's position. Track 1, as you know, is a temporary track. It was never intended to be a permanent track. They stay in it for a period of time, and either they succeed or they fail. If they fail, they leave the program. And that was, planned obsolescence for track 1. We're not going to continue to support practices that don't provide bona fide advanced primary care. So the question is, how we go from, and that's obviously that's going to happen anyway. Will track 2 morph into something else? That's an open question. What will track 3 look like? That's what we're in the very aggressive process of trying to define now, if we can do that in this very short order that we've been asked to do it.
So I think Bob brings to light an important point. Let's just make sure that other council members don't have questions after the response that Dr. Hack provided to the group. And then I would also ask Bob, I heard multiple questions in your question. Did we address all of them? Or does it seem like we covered it sufficiently, or did we miss something?
Bob, in the interest of so you know, our third agenda item and priority was exactly this conversation about track 3, whether the committee feels like it should be mandatory, what mandatory means, what track 3 means. And so we are planning to have a significant conversation about this further down. It's certainly worthwhile bringing it up now, but that is on our agenda to have a significant conversation about track.
Okay, so I absolutely don't want to hijack the conversation. I'm sorry.
No problem.
I was so busy fiddling with the technology that I missed the review of the agenda and that intro. But just wake me up again when you get to the part where we talk about whether primary care physicians, or how much primary care physician risk for total cost of care is going to overlap with the total cost of care models incentives that hospitals have a role in.
Yeah, that's a good point. Any other comments from the council members before we go back here? There is an unknown. Melanie, can you read that? There was a chat comment that just came through.
Yes, I'm not sure who sent it. It says the 2020 fee for code 99212 is $46.13. I think this is supposed to be 2021 proposed fee is $54.20 pay levels. Both PMPMs and visit rates should not be frozen to the year when the RFI was released, in my opinion. Was that you, Dr. Berenson?
It certainly was.
Just on my part.
I just want to comment about when the RFI was released, and there'd be an escalator clause. I mean, some kind of.
And Alana, if you want to capture that point. Okay. All right. So before we turn back to Dr. Riedman, I think what we're hearing is that what's proposed in the blue or teal, whatever you're calling this column, there for numbers 1 and 2, the council doesn't have any significant changes to propose other than what we see typed in the last column on the requirements grid. Is that fair to say? Did we miss something? Are there other comments that we should put in here?
Alana, I think we bring up, there are 2 big important points there. One is that, that $40 flat rate needs to be adjusted for the actual rates when the program goes in. And I think the escalation yearly certainly needs to be, that fee needs to change as the program changes. And if the fees go up for that, whatever we decide, whether it's a level 2 visit or something between a level 3 and a 2 or whatever, that needs to be an escalation each year. And I think the comment about making it, a little bit higher, closer to a level 2 or a level 3 visit, as was mentioned, we do very, very few level 2 visits. Medicare patients are our most complicated patients by far, and to go with a level 2 visit as a flat fee, I'm not sure that that's appropriate either. So I think those need to be in our suggestions, and I think those are great suggestions.
Michael, this is in Kemp.
Dr.
Can you hear me? This is in Kemp. Yeah.
Dr.
And just to add to what you said, if you look at that one pager that was up there, if you look at the bottom part of it, It also mentioned some things that will be taken away if we move to this new payment model. Yeah, keep scrolling down. And you see that there will no longer be reimbursement for AWV, TCM, CCM. So I think in the analysis, it would be nice to kind of do, kind of a pre and post analysis of some sort where providers can understand what is being taken away from me and what do I stand to gain, so they can buy into this, flat fee payment for services.
Okay, Alana, if we can add that. I will note that the American Academy of Family Physicians has done some modeling. So you can read their summary on their website. It doesn't show the actual modeling. It just shows their assessment of that. That's about as close as we've found at the moment by looking at how that might look. Although we are pressing CMMI for information about the modeling. Thank you. It's a great question. Dr. Berenson, then Melanie.
Yeah, I wanted to pick up on Dr. Reedman's comment. The utilization, the most commonly billed office visit now has become level 4. I think that does reflect some upcoding, but it's certainly not a level 2. And by my back of the envelope calculation is if you sort of took an average between level 3 and level 4 and discounted it maybe 40% because we want to pay something closer to marginal costs rather than average costs, you'd get between $60 and $70, and that's probably, I think that's a logical place to wind up. I'm not sure why they picked a level 2 to begin with, but I think we want to pay for a visit, in my view, so that the physician has sort of an incentive neutral, is incentive neutral about generating the next office visit. It's neither profitable nor is it a loser, and that's sort of estimating the variable cost of an office visit. And if office visits are level 3s and 4s, then I think one could do that calculation. There may be a reason CMMI has picked a level 2, but I'm concerned that they picked it and then didn't update it to try to save money.
Yeah, good point. Thank you. Melanie, your thought, you had a reaction?
Well, I just wanted to give an opportunity for the council members that may be on the phone, because we do have a few of them, if they wanted to interject on this issue. So some of them have been texting me. So you can use the chat function as Bob Atlas did to let us know that you have a question. But does anyone on the phone who's on the council have a question at this time on the payments or want to add something on the payments? Okay.
Okay, so I think we're okay.
Sorry, this is.
Yes.
Sorry, I don't have my camera set up, so I can't do the raising of the white sheet.
No worries, Will. Go ahead.
So this is Will from HSCRC. I guess I would be interested from Bob and others' perspective. The payments are split between the population-based payment and the per visit payment, right? So the total revenue is probably expected to be at or equal or above what practices currently get paid. Does it matter where the distribution of that is between the lump sum payment versus the per visit payment?
Anyone wish to comment? Dr. Berenson?
That's a policy call. I think you want more of it into the PMPM. To me, the concept is how much you have to discount the fee schedule so that docs are sort of indifferent as to whether they're billing for services, in this case, office visits. But that's my concept. I don't know that anybody else in the world has accepted that. I think my family is not on sort of agrees with that. But my basic point is that the total pot should be increased. And then we can figure out whether it should go into the PMPM versus the visits. And that's a perfectly reasonable policy call. But mine would be to try to create incentive neutrality.
Yeah, good point.
Right.
Station. Sorry, Will. Please continue.
So I guess my comment would be that I think the capitated payment, as you said, is probably better from divorcing people from churning through office visits. But it's interesting that the risk adjustment is applied to the population-based payment and not the visit payment, right? I would assume that your incentive compatibility issue would be trying to ensure that people who are paid an average visit per rate are not then avoiding providing the visits to high risk beneficiaries.
Well, I was never a fan of going to a single visit rate. That's an inherent problem. One of the merits of a fee schedule payment is you maintain risk adjustment by definition. A very complicated patient who's a level 4 or level 5, you've adjusted for it. A single visit rate is a lot simpler and you don't get upcoding going on. But if you're concerned about risk adjustment, you wouldn't go to a single visit rate. I mean, there's no perfect answer here. I can understand going to a single rate. I would prefer going to maybe 2 visits, but it seems like that horse is out of the barn already. CMMI seems to feel that one of the strong merits to primary care first is to have a single visit rate. I don't agree with that, but that seems to be what they want to do.
Yeah, thank you.
And the risk portion of that, the adjustment to the population-based payment is done on a per practice basis, not on a per patient basis. In our current model, on a per patient basis, it adjusts. In this model, it's an important distinction that it adjusts on an entire practice. So practice is either gets paid at every patient gets paid at the same level, independent of what their risk is, just based on the average for the whole practice. So it's got cliffs rather than a gradation over individual patients, and that is a significant difference that we should pay some attention to.
Yes.
The other issue here, because we're comparing apples to make sure that they're and Will, I know, loves apples, is that are we comparing the apple that is the MDPCP current payment structure to this, or are we comparing basic fee for service to this proposal? And those are two different. The MDPCP has infrastructure, care management fees, other things built into it. Basic fee for service doesn't. So if we're gonna do a comparison, we should at least decide, which we're comparing it to, the current or the what plain fee for service would look like.
Yeah, and I think to Dr. Haas' point, we probably do want to keep it focused on the MDPCP as it stands today, as opposed to pre-MDPCP, if you will. I think Stacia had a comment, and then Melanie.
This is Stacia. Sorry, my comment was an echo of Will's observation, and that is that with both a population-based payment and a visit fee, that I don't think looking solely at the visit rate is reflective of what the actual cost of care will be.
Good point. Thank you. Alana, you'll make sure that's evident here and add a comment about that. And then Melanie, here.
So we have an email from Scott Rose. He had a question. Are these changes going to affect the ability for us to bring Medicaid chronic health forms into the program in the future?
Dr. Haft.
It's not been contemplated at this point. I think we'll have to spend a little time to think about that. I hope not.
Okay. So, Dr. Riedman, are you comfortable if we move on?
Sure. I just want to make sure there's no more comments on that first section. Certainly appreciate everybody's feedback on that. So if not, you want to move down, Alana?
To the next shaded area.
There you go. Good. Okay. So this is the performance-based adjustment. So again, you can read the first part of the second. Our turquoise column, I guess that's turquoise column is. I'll go through that. And some of it's the same. The performance-based adjustment. Practices are motivated to reduce ambulatory sensitive ED and hospital admission, reduce the total cost of care while meeting quality and experience of care threshold. The PBA is an adjustment to the quarterly performance-based payment potential, approximate percentage of primary care revenue. Practice can receive up to a 34% upside bonus or a 10% downside penalty adjustment based on quality and utilization achievement or improvement against national benchmarks. And practices can earn up to 16% bonus under the continuous improvement bonus. The matrix of the adjustment to the PBA will include a minimum of 3 quality measures aligned with the Maryland State Health Improvement Strategy, One of patient assessment measures of patient assessment of comprehensive care, and measures of the PQI elimination performance. Practices in track 3 will have already had the MDPCP experience, eliminating the need for year 1 adjustments. Can you scroll up a little bit? Alana, scroll down some. Yeah. Sorry. The one measure of a patient assessment comprehensive care, I think I just read that. It was lost in place there. And then practice in track 3 will have already had the adjustment, and the practices TPCP will be adjusted as described above. I think that's it on that column. Is that correct? Can you scroll down? I think yes.
And Doc, go ahead.
No, go ahead.
So there are 2 points here that let me just call out. For practices to receive a positive adjustment, there's 2 components. There's the quality gateway, which includes a minimum of 5 quality metrics, and there's also performance on the acute hospital utilization. So if I were to guess what Bob Atlas's next question will be, it will be regarding a policy around are we going forward with the acute hospital utilization benchmarks, or was it the preference of the committee to not use those benchmarks and not use the acute hospital utilization component? And Dr. Haft, when you are talking about where CMMI's responses were, you might want to focus a little bit on that area as well as the quality gateway.
Sure, absolutely. So first, just as a way of understanding this in a little bit more detail. First, it is complex, very complex, the way that the adjustments are made.
Yes.
But the first level of adjustment is that to be eligible for any bonus at all, the practice needs to be greater than the national 50% benchmark for hospital AHU, avoidable acute hospital usage, which is a HEDIS measure. So that's to get on the playing field. If a practice is below 50% and they happen to be in the bottom 25% of all the practices in the program, then they get automatically a 10% reduction. And then depending on where they are in that range, somewhere between the bottom 25% and up, would be a proportionate reduction until they get out of the bottom quartile. So you need to be, you first are measured against the nation and then against peers in order to get into the bonus adjustment. The bonus adjustments then have to do with the 5 measures, which include, as they're configured now, diabetes, hypertension control, colorectal cancer screening, CAP scores, and again hospital utilization. So it's and then they're I think adjusted on a quarterly basis, I believe. There are also leakage. There are leakage adjustments and some other adjustments that are made in the metering out of these. The question that we raise, first of all, is very, very focused and very pits practice against practice within the state, so that practices could substantially be doing fine relative to whatever the reducing utilization, other things, but if they miss certain benchmarks, they could have a significant reduction. And it particularly in the competition within the state, it was a fairly I think pitting one against another for bonuses is a strategy, but not a strategy that we thought was necessarily a good one, particularly with a significant downside. More than that was the issue related to the currently MDPCP aligns our incentives and our quality measures with the state's population health goals and across the board. And we've had the opportunity to annually to make adjustments of those. We obviously made adjustments in terms of the past, in terms of substance use. We'll look forward to doing things that are aligned with diabetes prevention in the future. and other things such as they are things that are within the state population health goals. This takes that out and puts both the amounts of adjustments and what the adjustments are related to based on other CMMI goals and not perhaps the aligned state goals. I think we agreed that adjusting by avoidable hospital utilization was a worthwhile goal, and as much as that reducing avoidable hospitalization will affect total cost of care, that should be included in it, and perhaps also a measure of total cost of care overall. But the way this is configured currently, this seems to miss the point in terms of what's happening within the state, and specifically within the total cost of care, model contract, and global budgets. It's not well aligned to that.
And Dr. Haft, the feedback from CMMI staff?
They just wanted to have their simple feedback was give us a rationale.
So before we open up to other comments, I think Howard brings up a couple of important points. One is the complexity of the formula, as Howard explained it. Anything that's going to work, we're talking about a lot of primary care physician offices, a lot of smaller offices. The physicians they're concentrated on seeing patients. They aren't MBAs. They don't have MBAs working for them. And a little bit easier for some of the more sophisticated practices and larger ones to keep track. But if the administrative burden for reporting these measures falls into the practices, that's an issue. And I think it's the complexity of the formulas. The more complex, the harder it is for those in particular smaller groups and average primary care groups to understand that. And that gets into an issue of participation. It gets very difficult when you don't understand how you're getting paid and how this formulas work. So I think the simplicity of the formulas needs to be there, and I think that it needs to be spelled out. And I think the administrative burden to the practices, the reporting has to be spelled out. We've had that conversation before at some of our previous advisory meetings, but I think those are important points as we go through this. So I'll open it up to the floor for other comments.
Kathy, and then Bob.
Right. Can you hear me?
Yes.
Okay. I want to echo what Dr. Riedman said. The administrative burden for us has been humongous. We are a small practice. We have a affordable EMR that is great for patient documentation, but it is horrible reporting. Almost every single report that we've had to submit has been done by hand. And I can't tell you that, I'm sure you can envision it takes a whole lot of time. Last November, it came out that CMS wanted the E&M code on every visit. We were one of 4 or 5 EMRs that didn't do that. We spent 100 hours in January and February going back and adding the EF code to every single visit, so it would count. ECQMs, you talked about different things that could be tracked, one of them being colon cancer. Our EMR actually dropped that as a tracking. They narrowed the ECQMs down to, I think, 7 or 9. That is not one of them. So those of us who have a very, less expensive, if we don't have ECW, we don't have that. Doing some of the reporting, if our EMR doesn't capture that and track that, it's going to be very burdensome. So that's one thought I have. The other thought I have, concern I have, every time we talk about additional risk to the practice, it makes me nervous. Our county, either 2018 or 2019, was deemed the most unhealthy county in the state of Maryland. We have low socioeconomic, we have a high incidence of elderly. Our HCC score is always above the state. I get nervous. Can I really make a dent in that population out here? And if I can't make a dent, then what does that mean for me, for the risk I'm taking on as a practice?
So just one quick comment in terms of the administrative burden. I think that this model does serve to reduce administrative burden. So it's not any more burdensome and perhaps less burdensome in some ways. That was part of the model design. So I don't think I would fault it in any way for that. It does have complexities in terms of the understanding of what you're going to get paid from quarter to quarter. I think that was mirrored in with the comments that the American Academy of Family Practice had in their comment section also about the lack of predictability of cash flow.
Okay. Dr. Reed, any response?
Actually, I think Kathy brings up a couple of points. I'm not sure how pertinent it is to our conversation about what we have control over for the CMS, but our group actually switched about 2 years ago to Epic, which is an outrageously expensive program. But it does do a lot, and it does the reporting for us. And in particular, our illness burden scores dramatically increased only because our former EMR just made it extremely cumbersome and difficult to pick those scores. And what happens is, it doesn't mean you're not taking care of those patients. If your EMR is not robust enough to do the reporting, which a lot of the older ones not, and the ones that are less expensive are not, that's a really important point for the primary care physicians that are going to be asked to, like you say, anytime you put administrative burden or reporting responsibilities on them, or even reporting the appropriate HCC scores, EMRs have a lot to do with that. And I'm not sure how we address that at this committee at all. But it's a really important point that she brings up, that a lot of this is dependent on the EMR, and our Epic system has definitely made our lives easier. But we're kind of unique in primary care. There aren't a lot of primary care groups that can afford the Epic program. So I think that's a really important point she brings up.
Yeah.
So Michael, I can add to that. Oh, go ahead, David.
No, I'll follow. I yield.
Sure. I can add to that with CPC Plus implementation. This is going to implementation. I will pivot back to the performance-based adjustments we're talking about. But with CPC Plus, some practices were engaged with their health IT vendor and EMR vendor to actually do a comprehensive business requirement assessment. And this was for track 1 practices that were trying to advance to track 2. So it almost wanted to have this comprehensive report that states, for the technology I need to advance my primary care transformation, where are the gaps? And then they could have, a clear conversation about what needs to happen before they get to track 2. And now that we're talking about performance-based for track 3, right, we should have criteria which might include capacity of your EMR to not only capture patient information and data, but also reporting, and how do we kind of tie that into criteria, but then again, scale back into implementation in the here and now to really have either CTOs, the PMO, whoever else to really support practices to get to this quote unquote advanced primary care that we all dream about, because you cannot do manual reporting in an advanced primary care model.
So one of the elements, Alana, we want to include is under primary care first, practices are required to have a 2015 certified EHR. And I think what we heard Dr. Reedman talk about from Epic is because they are using that version. Maybe we need to explore a little bit with CMMI or with the MDPCP, those that are not on a 2015 or would be able to move to a 2015 version in any kind of track 3. And
all of our practices now are on 2015. So
okay, so it's
I think the level of sophistication of those programs is extremely varied. And our old program was certified and all, but again, it's light years. Epic is even though it's difficult transition to Epic for our providers 2 years ago, it's been light years above the reporting and all of the administrative burden we have. But it's really almost a cost prohibitive program for primary care physicians.
I agree, and I think they need to have another. I don't know all the components that go into the 2015 cert, but I think there needs to be another level of capability requirements, because just like Michael had mentioned, a lot of practices have this EMR, their 2015 cert, but I mean, it still doesn't do what it's supposed to do in terms of real-time data, actionable to close care gaps, and ultimately have performance-based bonuses.
Okay, thank you. Bob, I think you were going to make a comment.
You're talking to me? There's two Bobs here. Are we?
Oh, yes, Bob Atlas.
the world is losing its Bobs, but there's still some of us. So going back a few minutes to the thing about whether the incentive should be on hospital utilization. Obviously, hospitals have that incentive under the GBR, as I think Howard pointed out. And so there's either, one could say this is alignment on the one hand, on the other hand, it's conflicting. I mean, if you're going to pay a bonus to primary care practices for reducing hospital utilization, but in fact, you've got a GBR where the spend doesn't actually go down in the short term for reducing utilization, you're paying out money that sort of you don't have. And I'm just trying to get a feel for the order of magnitude of these payments. I mean, we know that right now care management fees and all that is what, about $120, $130 million a year. Do we have any clue as to, what the future looks like if either just the base payments, setting aside payments for services, is this going to inflect payments materially, and do the bonuses or penalties go into the calculation of total cost of care in any material way?
So, Will, are you still on? And if you are, can you weigh in here?
I am still on. You would like me to weigh in on the
Yes.
of the potential into primary care?
Yes, please. To Bob's point.
Yes, I mean, it's very expensive. And I think that if you add sort of upside risk that goes up to 34%, it would be, potentially an extra couple $100 million. That's probably not a realistic number because it assumes that everybody does very well. And so I think it varies based on the program design. And if you have, sort of a zero-sum game with practices competing against each other, then, that outcome looks different. But
well, so that evokes a question, and now you're scaring me when you say $200 million. So are these incentives meant to be budget neutral, so that that rewards to practices that do well are only funded if there are penalties from practices that don't, or is it money from the beneficent federal government regardless? And are you suggesting, Will, that incentive payments on top of service payments and care management fees could add up to $200 million in 1 year?
yeah, so I need to contextualize that. I think we don't know, because we don't know whether the PBA, what the PBA is based on, and whether it's how it's benchmarked to the region, or how it's benchmarked to practices within the state. So I think it varies. I do think we are talking about a significant amount of money, and if everybody received the maximum upside payment, it would be, I think, on the range of several $100 million. I think that outcome is unlikely under any sort of reasonable program design, but I think that's up to CMMI and then our recommendations to them.
So, Dr. Hafkin, I don't recall seeing in the RFA that it specifically said it's budget neutral. I mean, there may be it may be implied a bit, just because, as Will is mentioning, there'll be some winners and losers. But do you recall seeing anything specific, or having CMMI indicate that it is actually written as budget neutral?
So I have not seen that. We've asked that question. I think that the staff at CMMI were going to try and find an answer to that question for us. I think that certainly there's no, and Will can correct me, in the controlling statute, there's no requirement for it to be budget neutral, only that the model is needed to either or improve quality of care or reduce costs, or both. But I don't believe budget neutrality was a mandate for the model.
So the total cost of care model, I think there is a mandate that it is sort of budget neutral. And then what does budget neutral mean is an interesting question about baselines and various things. But I do think CMMI's interpretation historically has been that the model has to reduce cost or improve quality without increasing cost.
Dr. Berenson, thank you, Will. Dr. Happ.
Yeah, to complicate matters a little bit more. I was for a different activity that I'm involved with literally 2 days ago. We were discussing the role of incentives to primary care physicians to reduce hospital utilization. This is not in Maryland, but sort of as a national model. And another participant claims and sent around 4 links that primary cares, in fact, are not successful at reducing hospitalization. Where it's been tried, it hasn't been successful despite its sort of plausibility. And so that just, we may all be kidding ourselves that primary care docs actually strongly influence hospitalization rates. And so weeks ago, I suggested maybe we want to focus on referral rates from primary care as a better metric, and it wouldn't get into the mix of the fact that the hospitals already have an incentive in Maryland. But the fact is that it may not be accomplishing anything.
Yeah, thank you, Bob. If I may just jump in quickly, we've got these goals under the MOU, the SciHIS, the population goals around diabetes and opioids and so forth, and maybe, best if we can get everybody lined up on the same goals. So maybe that would be a better place. Managing people with chronic conditions is something that a lot of primary care physicians are doing. And picking up on what Bob just said, you don't have to get into the question. Getting it into hospital utilization is questionable for multiple reasons, particularly in light of the Maryland model design.
Yeah, that's a good point. And the measures that are proposed, as we get deeper into the discussion, does talk about aligning the measures with the state measures that are underway here in Maryland. Dr. Riedman, is it fair to say that we're hearing there's a lot of clarification questions and comments, but there really hasn't been any departure from what is been proposed by the subcommittee at this stage?
Yeah, I think that's fair to say. I think that we bring up really good points, and I think we had talked at the subcommittee also about how do we measure quality, and I think that's just our conversation tonight reemphasizes that that's a really difficult thing to get at. We talked about again, there are specific measures, but that doesn't really measure the fact that my patient's A1C is 8.3. Is that really a measure of the quality that I'm providing to that patient, the quality of care they get in, the quality that to extend their life and prevent hospitalizations? And I think that we had I think Bob brought up at our subcommittee that there may be some other better ways to measure that we had discussed. And I think that's an important point. We suggest to CMS that maybe there are better ways. The problem we have is that because of our timeline and because of the program, I came into this with a vision of we could do this, and this. The reality of it is that if we don't stick close to what they're already suggesting, we're not going to get anywhere with them, and our recommendations are not going to have any meaning. So, I think it'd be great to reassess how we measure this. I think this committee should make some suggestions to CMS. Having said that, I think we need to keep at least close to what they're suggesting to make any kind of impact in the time frame we have. But I certainly think that we can make suggestions that we feel like as the program goes forward, we'd like to access these measures. And that may be the best way. My understanding from Howard and some of our other meetings was that these are our initial guidelines and this is our initial recommendations, but this program is going to fluctuate and change and be modified as we move along. So if we start off this way, it doesn't mean we we are fixed to any of this as we go along. Hopefully that we'll be able to make some changes and suggestions and amendments to them as we go along. So I think we're on the right track for where we are right now, David.
Okay. We have, Dr. Reedman, a little more than 5 minutes left on the clock, 7 minutes-ish. How do you want to proceed at this stage?
I don't think there's time to get into our, we got through the first item, which was what we were hoping for tonight. It opens up some questions. It certainly gives everybody a chance to think about it. What I think I'd like to do is kind of wrap up our meeting tonight. We have two more important agenda items that I think we'll be able to get through next time. And one of those was about track 3 and how we handle that, whether it's mandatory, et cetera, and some of the performance measures. So I'd encourage everyone to look before our next meeting at those, and if you have any ideas. What we did with our advisory committee, the subcommittee, and what I'd like to do with this committee is hopefully get through our second agenda item, or the end of this agenda by the next meeting. And maybe the third meeting, have the opportunity to quickly move through, I think, some pretty straightforward items on the agenda, and then double back to these important ones that we're discussing tonight and next week, so we can give everybody a chance to think about them and readdress them before we come up with our final report. We're hoping to have at least 3 to 4 meetings total before we hit our deadline. We do have the holiday coming up in September, so why don't we wrap up tonight, and Melanie, you and David can talk about our further meetings, and then we'll go from there.
Dr. Reedman, if I could just add on to your point, what we will do, because there's a lot going on in in this category where we talk about the PBA, and we will send in an email. We'll include the pages of the RFA. If you get a chance, the RFA is thick. There's lots of pages to it, but rather than going through all 102 pages, if you will, if you go back and just look at certain pages related to the PBA, it may help. And it may spur some additional thoughts that you might have that you weren't prepared to share tonight, or it didn't pop to your mind. You can send us those via email, and we'll add them to the matrix, so you won't have to wait till the next meeting. So with that, I can jump forward a little bit. We have joining us on the call the MHCC's executive director. If we were in person, I would have asked him to make some remarks, but he is on the line. I wanted to give him a chance to, Ben Steffen, a chance to make any comments regarding the work that's underway. And you may be muted, Ben. Or
I am muted, and I don't think I have anything to add. I think the points, one of the big challenges as the program deviates from primary care first is just how meaningful benchmarking this program to a national composite of practices might be. We would get enormous pushback if we had a statewide benchmark, but it would be a benchmark that somehow reflected overall performance among primary care providers in the state. Might be a way to make it both more challenging, but potentially more attractive to fit into the total cost of care model. But I think as we think about this as a model that's different from primary care first, the basis for using national benchmarks seems to me to be reduced. And I think people made a couple different points, all of them equally convincing to me, which makes me probably the most gullible listener of all of you. But I really appreciate I think the thoughtful comments from everyone. I encourage everyone to continue to think hard about this as we go forward. I think a central pivot point is just how different this program the track 3 will be from primary care first. And as we pivot into a slightly different direction, what types of concessions we might be able to wrestle from from CMMI.
Great. Thanks, Ben. I just wanted to make I'm going to turn it back over to Melanie to help with our next meeting, but I did want to make one comment on our final agenda item there that we did get a request, I think it was today, if I'm not mistaken, from the annual report review that the PMO requested this committee to give feedback on that report. I think it's 42 pages, is that right? Lana or Melanie, but
I think that's
we are going to send that out, and then yeah, and Stacia has a question, but we are going to send that out to the committee for y'all to look at. So at some point when we get through, we'd like to have further conversation about it. Stacia, do you have a question before we wrap up?
Oh, I was just asking if you were going to send out the PMO report. That would be
Yes.
helpful.
Yes.
Thank
Yes.
And Dr. Reedman, just to remind everyone, comments are due on the 1st of September. Dr. Haft, is that correct?
That's correct.
Okay. And that is just the first draft. Is it? Will there be a?
That is correct. Just want the advisory council to put eyes on it, comments and things that large areas of agreement, disagreement, anything you think we left out or anything we can do better. This is a report that we'll submit to CMMI at in the end of September timeframe. The only thing that's missing from this draft report, and this is I think emblematic of things that we're talking about tonight, also is that it takes a while to get the adjudication of the performance adjustments, so the quality, utilization, and patient satisfaction pieces have not yet been reported from 2019. So this is put that in the context of trying to do that every quarter in the current design.
So Melanie, you have 45 seconds.
So just very quickly, the Google sheet that we were all looking at, that table, serves as a record of what was discussed at the meeting. That will be sent around to all the advisory council members. We will be sending out an invite to everyone, as Dr. Reedman mentioned. It will be on Tuesdays in this same time slot from 5 to 6:30 for the next few weeks. And we will also be publishing all the meeting information and the recording on our MHCC's website. So you can go back and listen to the recording if you would like, and then also the information for the next meeting will be posted there as well for the public. Did I miss anything, David?
No, I think you hit on everything. And lastly, I would say this group is a very impressive group that's done a lot of great work. We hope we've energized you enough to want to come back next week. So with that, Dr. Reedman, if you have no other comments or anyone else, we'll close it out from here and wish everyone a great rest of the week and look forward to talking to you again next week this time.
Thank you, everyone.
See you, everyone.